I'd like to introduce Ian Williamson. Ian was as the Interim Chief Officer for the Greater Manchester Health and Social Care Devolution. Professor Ian Greer, who's the Director of the Manchester Academic Health and Science Centre and is also Dean of the Medical School at Manchester University. David Dalton, Sir David Dalton, Chief Executive, of course, of Salford Royal. Anne Barnes, Chief Executive of Stockport NHS Foundation Trust, and also chairs the Provider Forum in Greater Manchester. And last but not least is Dr. Ranjit Gill, Chief Clinical Officer of NHS Stockport CCG. Ian. Okay.
Yep. Good morning. Oh. Good morning. Welcome again to Manchester. Manchester is famous for many things, including its football. Unfortunately, I'm a Bolton Wanderers fan, and as I see people leaving the stage and others arriving, I'm hoping that there'll be a decent crowd here, and perhaps even better than a Bolton Wanderers crowd. Let me just, if I may, start off by setting the scene a little bit about health and social care devolution in Greater Manchester before my colleagues give more of a personal perspective on why this is important and the opportunities that it brings. The main aim of our health and social care devolution journey and experiment and programme is to achieve the greatest and fastest possible improvement in the health and well-being of the 2.8 million people of Greater Manchester. Everything else is a means to that end. And that is a shared ambition from all of the partners working on this programme in our conurbation. So the 10 local authorities, the 12 clinical commissioning groups, the 15 NHS provider organisations, together working in partnership with primary care colleagues, with the voluntary sector, and of course with patient groups and the public as well. So it's a big, broad tent that we want to operate within, and we are enthusiastically pursuing it. Let me just outline some of the key principles which underline our work. The first and perhaps most important one, which is driving this approach, is our desire to have all decisions about health and social care in Greater Manchester made in Greater Manchester and by Greater Manchester. So that is a key principle and approach for us, is to try and locate all the decisions that we make within Greater Manchester to be made by those people in Greater Manchester who know the patch the best, rather than perhaps some of those decisions being made in London or Leeds or elsewhere. We think that we are at least as capable of making those decisions locally with the proper advice as others. The second important principle is that this is a programme which keeps Greater Manchester within the NHS. So we're not leaving the NHS, contrary to what some of the press reports may have suggested. We are still subject to the NHS Constitution, we're subject to the annual mandate, and we embrace and will pursue that with vigour. Of course, we want to do some things differently in Greater Manchester, and we'll talk a little bit about those. But the key principles of still being part of the NHS are strong. One of the key next principles is the opportunity for us to operate much more broadly outside of health and social care than we have to date. So by working with our council colleagues, for example, we have a chance to really look to address some of the key determinants of health that we know are so important if we're going to improve the health and well-being of our population. So employment, housing, and education are all issues that this agreement gives us the opportunity to shape and work on much more so than in the past. Howard has already talked about people and place, and how we really want to get our focus on what works for the population and what will help them to be healthy, rather than just what works for our institutions and our organisations. We represent about 5% of the NHS and social care system within England. So we think that that scale gives us the opportunity to do things together and to have an impact on services and on health that is much more broad and much more powerful than if we just operated individually. I talk a lot about Greater Manchester, but as important is the principle that we want decisions to take place as locally as possible. It's what some people call subsidiarity. So it's very important that this isn't seen as a gathering together of all the power and all the money in a small number of people's hands in the centre of Greater Manchester. That's not what it's about. It's about ensuring that the decisions that need to be taken locally in our 10 different boroughs and our 12 CCGs continue to do so, but we make those decisions and shape those policies together where it makes sense across the whole population for Greater Manchester. So we do what makes sense at locality level, and we do what makes sense at Greater Manchester. And the final principle is that one of health and social care. We strongly believe, and we know that the evidence tells us, that outcomes for patients are better if our services are joined up, if we are delivering health and social care in an integrated way. Finally, from me, just to explain where we are on our journey, we're in a build-up year during 15 and 16 prior to going live in full devolution form by April next year. We're about to enter 6 months of a shadow stage where we have the new governance arrangements in place, which bind us together and help us to make clear, positive decisions. We're in the process of agreeing our budget for next year. We currently have a budget that we control within Greater Manchester of about £4.5 billion a year. We think that by next April, once we've taken on primary care and responsibility for specialised services, that will be well in excess of £6 billion a year. And crucially, by the end of this calendar year, by December, we will produce our overarching plan and strategy for how our services and how our population's health can improve and how our services can be clinically and financially sustainable. We will be setting out our ambition, our clear plans for how we will turn the health of our population around. Thank you very much.
"17 years. Ladies and gentlemen, it takes 17 years in the UK on average to take a care innovation through to routine practice. 17 years is too long. Too long for our patients, too long for our NHS, and certainly too long for our economy here in Greater Manchester. Despite major investments in health research, it remains very difficult to bring research that benefits health directly into patient care. So we need to streamline that process for research to deliver better health outcomes for Manchester. Now, at a national level, it's perhaps unsurprising that it's difficult because of the complex and fragmented innovation pathway that goes all the way from discovery science through to patient care. With so many different organisations and their complexity, one might not expect a smooth, streamlined path at a national level. And all too often, these factors inhibit an invest-to-save approach. And investing to save is critical if we want to get new research into practice, because the savings are not always realised at the site where the investment is made. However, here in Greater Manchester, we have both an imperative and an opportunity to address this. The imperative is the scale of the health challenge here in Greater Manchester. It's a very significant one, much greater than in many other parts of the UK. And we need to deliver the best possible health and social care to our people. So we have that imperative. Tackling that problem will lead to a healthier population. It will save costs to our NHS in Greater Manchester, and it will make people more able to work, therefore driving both productivity and, of course, economic growth. Indeed, it's estimated that for every £1 spent from public resources and medical charities on medical research, that there is a 30% per annum return year on year. That's an investment that we can't get anywhere else. That's an investment that we should be making here in Manchester because we can capitalise on that opportunity. Now, Manchester is well placed to capitalise on that opportunity because we've got very great assets when it comes to internationally leading medical and health research, made prominent both by the University and Manchester Academic Health Science Centre. We've got major strengths, such as in cancer treatment, where we're one of 3 major CRUK institutes, along with Oxford and Cambridge. We lead internationally on e-health and health informatics. And when it comes to precision medicine, we've got an enormous opportunity because here in Manchester, with the combination of science and e-health, we can practice precision medicine. Precision medicine isn't new drugs that somehow solve major problems. Rather, it's about looking at our patients in a better and a more holistic way, identifying their specific problems and giving them the right treatment at the right time in the right dose to ensure that it's both safe, effective, and cost-effective. So we've got that enormous opportunity. The opportunity of devolution. That gives us the ability to link the rich medical and health research and innovation pipeline here in Manchester directly into patient care, so streamlining the adoption of innovation into routine practice through NHS procurement and commissioning here in Manchester. By having that holistic approach to health and social care, we can deliver that invest to save approach, investing in one part of our discovery care continuum to reap the benefits in another. That approach, I believe, is essential to quickly translate the opportunities that we have from research into an improved health outcome for our population. Furthermore, businesses, and there are many businesses here, report difficulty in getting cost-effective care developments taken up by the NHS. So the system that we have in Greater Manchester will also attract industry because we'll have an integrated for the first time in the UK, our health infrastructure, our patient population with very high morbidity, our health services, creating a streamlined path to NHS adoption through that local commissioning and procurement model that you've heard about. We believe that this is a model for the future, not just for Manchester, but for the UK. And these benefits will flow well beyond the bounds of Manchester. Particularly, it will flow across the north through established collaborations, because Manchester is part of the Northern Health Science Alliance, which brings the whole of the North's health economies together and lets us work together in a collaborative way to make us truly competitive on the international stage. We'll also build on the investment by the Chancellor. He set up the Northern Powerhouse, and in concert with that is Health North, and we received £20 million in the last budget to pump prime that development, to connect up health, social and civic data to better manage our patients, better manage our services, and better deliver on our research agenda. So we have an enormous opportunity. And to capitalise on that, we're joining up all the various components in Manchester to create a new health innovation system, Health Innovation Manchester, that will be launching later this evening. And that will rapidly realise these benefits, taking research into care pathways, improving health outcomes, and for the first time in the UK, creating a truly integrated system. So with devolution, I believe that we're able to make the step change in healthcare required to get those better patient outcomes, whether it's from better preventive medicine to more cost-effective management of acute and chronic conditions. So for me, devolution, I believe, is a once-in-a-lifetime opportunity, an opportunity to make a real difference, to make something special, to make a new approach that can change how we deal with health in the UK. And with Manchester's rich heritage in textiles, I'm reminded of a 19th century poem that, for me, captures the opportunity for research and information that can transform health. It goes like this. Upon this gifted age in its dark hour, rains from the sky a meteoric shower of facts. They lie, unquestioned, uncombined, wisdom enough to leach us from our ill is daily spun, but there exists no loom to weave it into fabric. Devolution, ladies and gentlemen, gives us the opportunity to make that loom here in Manchester, a loom that will weave research and innovation seamlessly, not only into better patient care, but also economic growth.
It's always very difficult to follow a poet, but I shall have a go. You heard earlier from Sir Howard that Greater Manchester is in the process of designing one of the biggest transfers of power that the NHS has experienced since its creation in 1948. And with that power comes responsibility to shape the future of our services with our communities, to keep decision-making close to the ground and allow political leaders to be more accountable for creating integrated services and reforming our public services. So we have a huge opportunity, I believe, to blend our resources and talents for the greater good of Greater Manchester. Now, Greater Manchester is far from perfect. We have poor life expectancy. We have high levels of deprivation, and we have large numbers of people who find difficulty getting back into work. We also have large variations in our services and in our patient outcomes. And it cannot be right that we have a 12-year difference in life expectancy between some of our neighbourhoods, or that 500 lives we know could be saved over 3 years if our hospitals could operate at the standards of the best, and that there is a 16% difference in mortality at the weekend compared with Monday to Friday. So these variations mean that we have an agenda that must be tackled. Now, I believe that devolution in Greater Manchester is possible because we have a proud history of being able to work together, a history of collaboration amongst our public service leaders. And devolution provides us with a platform for transparent and accountable governance with devolved power and responsibility. Now, last night, I was at a dinner with colleague chief executives, and we met to discuss how we might improve the way that we organise ourselves. And I think devolution is a catalyst for considering how we act in people's interests and not in our own organisational interests. So if we know the evidence of best practice, surely we are capable of being able to define our standards and then organising reliable delivery across our organisations. So we have the opportunity in Greater Manchester through the development, as Ian has described, of our academic health science system to tackle the key leadership challenge of assuring reliable delivery of what we know works for our patients. And we also have the opportunity of creating a standardised operating system capable of delivering excellence. Now, I don't just want this for my own organisation, for Salford Royal, because delivering excellence for a single organisation is not the answer to the challenges of Greater Manchester or our National Health Service. We need to be able to standardise at scale, and devolved authority provides an opportunity for us to set standards for Greater Manchester and then organise ourselves to deliver those standards. Now, at this stage, we don't know all the answers, but I was impressed last night by my colleagues' enthusiasm to talk about new ways of working. And already we are questioning whether 15 trusts is the best way to organise the delivery of high standards of care reliably. Do we need separate offices to pay our invoices, 15 separate recruitment offices, 15 boards of directors, when those administrative overheads could be redeployed into funding better care for our people? Now, the devolution team have asked me to lead a project to improve the lives of people living with dementia. I have to say this is a new field for me, and one that I approach with great caution, knowing that there are so many great examples across Greater Manchester of people who are already organising great delivery. But devolution provides an opportunity for us to set aside our local differences and agree how we can provide better and more resilient services which connect people living with dementia and people who care for people living with dementia to their local community assets. So we will design and prototype a new type of service in one of our localities, and we will link with our innovative industry partners in the field of digital technology, and we will connect with our fabulous housing associations. We will provide new opportunities for people to monitor their own health, linked to their neighbourhoods, connected to people who can coordinate their care. And with the support of colleagues in primary care and public health, we will also focus on how we can more reliably provide earlier diagnosis so people can get better, longer-term self-care. The Dementia Project is but one of our early projects, and I believe it will be a beacon for improvement across Greater Manchester. And unlike other projects in the National Health Service, a devolved governance structure can make sure that the best practices are adopted and spread across the whole of our conurbation. I have to tell you, I think these are incredibly exciting times for the NHS and for all those who work in Greater Manchester. Thank you.
Well, if it's hard following a poet, it's even harder following two knights of the realm and a professor. But I shall try and give you my personal perspective as Chief Executive of Stockport Foundation Trust, but also as Chair of the provider trusts within Greater Manchester. I think I'll start by saying, never mind Greater Manchester devolution, as a healthcare provider of both acute and community care, we are struggling to meet our financial requirements. For the first time ever, as an organisation of £300 million, we are likely to have a deficit of a substantial size. So we cannot carry on doing things the way we always have done. What we need to do, and we're doing very successfully in Stockport, is trying to find new models of care by working in partnership. And that is partnership with the Clinical Commissioning Group, with the mental health organisation Pennine Care, and within the council. And we have established something called Stockport Together, which is trying to make a difference for the population we serve. To absolutely understand that at the heart of the care we need to provide going forward is prevention. In Stockport, we have almost a microcosm of the Greater Manchester position. We have some very affluent areas with people who understand their healthcare needs and access them very readily. We also have some of the most deprived population, and they often leave the need for diagnosis and treatment until almost too late. We have got to do something about that. We have got to educate the public to be able to help themselves so that we can give them the earliest possible care. We've also established a different way to look at planned care and to understand how in proactive care we can manage more care out in people's homes in the community. And as one of the vanguard sites, we're working as that partnership in Stockport to make a real difference for the people we serve, to make a difference in outcomes, but also unashamedly to say we do not have the resources, financially or workforce, to undertake the level of duplication we are at present and to not work seamlessly for the people that we look after. Now, we're doing that without Greater Manchester devolution. But where Greater Manchester devolution comes is to understand if we can take that way of working in each of the organisations, in each of the localities across Greater Manchester, how much more powerful can that change be? And as a provider, I would like to say that I think Greater Manchester devolution is about moving from competition to collaboration. As a First Wave Foundation Trust, Since 2004, we've been working on a competitive basis. That is not sustainable. And so I am really pleased as chair of the provider trusts to say that we have got a completely new way of working. We've always worked together in Greater Manchester as chief executives, but mainly in our silos of acute and mental health. That is no longer. We now meet as a single group of chief executives. And we've also, as Sir David said, worked very much with our organisation in mind. We have now, in that collaborative way of working, got to move away from seeing only our organisations. I don't know what the future model of those organisational forms will look like. And actually, that shouldn't matter. What we need to be looking at is what the public needs, what pathways we need to offer jointly with health and social care working together, with commissioners and providers working together. The organisational forms will happen eventually, but it should never be the organisational form that actually leads what we're doing. As a personal perspective, I've been in healthcare for 35 years. I have never seen such unprecedented change as we've had over the last few months with Greater Manchester devolution. It has caught not just the imagination, but it is absolutely being seen by us in Greater Manchester as the only way forward to make sustainable the level of care changes and outcomes that we need for our population. When we signed the Memorandum of Understanding as partners, I talked about excitement. I talked about it being like the champagne bottle and the cork being removed and the fizz coming out. That fizz is still there, and we need to build upon that. We have immense will to make this succeed. And quite honestly, I don't think there's another show. So we're going to make this succeed, and we're going to learn our lessons of success and those things that we could do better on the way. Thank you.
Good morning. I'm the closing act. So I'm Ranjit Gill. I'm a GP, still working as a GP. I'm also chair of the programme board for Greater Manchester for the strategic sustainability plan that we're constructing. The first of its kind that I can think of, having worked in Greater Manchester since 1991. Which I guess says a lot about something, doesn't it? I'm an accountable officer for a CCG, and I'm proud to say that with my 11 other colleagues in Greater Manchester as accountable officers or clinical chairs, we, from the outset of clinical commissioning, recognised the potential power of a commissioner-led system of care. We recognise that part of the reason we have a high spend, poor outcomes Greater Manchester health system is because our predecessor commissioners failed to deliver on their potential and promise. Partly because they failed to work truly together to effect commissioning properly to deliver proper outcomes. So from the outset, we've decided to move in the direction of evidence-based care through clinical consensus, commissioner leadership, and we're not afraid to challenge the status quo. I think that's something of the clinical in commissioning. And from that, we've led and developed the program that you might know as Healthier Together, which is the large-scale reconfiguration of acute services across all of Greater Manchester's hospitals. We've developed primary care standards for all of Greater Manchester, which we plan to implement from 2017. from December this year, we plan to implement 7-day general practice across all of Greater Manchester. And we've completed the centralisation of hyperacute stroke services that began under our predecessor PCTs, but which had not delivered the improvements that we'd seen in London. But we've completed the job, and now, hopefully, we have a system that provides the best care for patients. We're all, in the United Kingdom, fundamentally reimagining the public sector. So outside of health and a couple of other government departments, other departments are being asked to reduce spend by massive amounts, 20, 30, 40%. Doing more of the same will not work. And in fact, in health, we know that we actually face a significant financial shortfall unless we fundamentally change the entire health and social care system. And we think in Greater Manchester we have the potential to help lead that change and demonstrate how a new model of care can deliver better outcomes at the same cost or less cost. Our aspiration is to be a self-insuring, self-assuring, and self-regulating system. So my personal perspective, so you'll forgive my navel-gazing for a minute here, but it may help to understand why I think what I think. So when I started out as a GP in 1991, I worked 24 hours a day, 7 days a week for about 3 years because I started out with wanting to provide the best care for my 1,400 patients that I started out with. I have to say, it nearly killed me. It's not a sustainable model of care. Then I had paper records. Now I have a partnership of 7 partners, 12,500 patients, electronic records. And if I think about what's happened in those last 20, 30 years, a great deal has happened. Our consultation rate has trebled. All the while, the population has got healthier, people live longer, but we've got a population that is now expecting, rather than hoping for, much better care. So if you think about the changes that have happened, just a few of the changes in my lifetime as a GP, we've got vaccinations aplenty. The new vaccination for meningitis B, which is going to hopefully eliminate the fear that many parents have when their child has a rash. It's a dramatic change that started yesterday. We have all sorts of other vaccinations. If you think about the program of vaccinations for children, we've got Hib vaccine, we've got meningitis C vaccine, we've got flu vaccine, rotavirus, and on it goes. So we're doing a lot already across the country to help prevent ill health. But our population no longer hopes that we have this. They require us to deliver it to them. We text message patients for appointments, reminders. We provide online access. But all the while, demand is rising. Expectations are getting greater and greater. And the way we currently work will no longer continue to be sustainable. The current GP consultation model for the GPs in the room only partially fulfills the potential of general practice. We need a new approach, fundamental redesign based on populations, but with the power of continuity that general practice provides, leading to, as Anne said, in Stockport, a multi-community provider in our vanguard status. And what we need is a health and social care system, as you've heard previous speakers say, based not on the profits of organizations or the organizational egos of providers, but instead based on the needs of people, of patients, and of populations. So I'm going to close with what the broad themes of our sustainability plan. And our sustainability plan is going to be tough on the causes of demand. The root causes of demand, we've heard, range from poverty, housing, environment, air pollution, variation in our health system, both variation in hospital provision and in primary care. And we're going to move to a new system of care based on prevention. And our mantra is going to be prevention, prevention, prevention. So I'm going to close with what I did yesterday. And what I did yesterday was give an 8-week-old baby her vaccinations at her 8-week check. And I found myself thinking, this child is the first patient I'd given meningitis B vaccination to. And she also had many other vaccinations. And that's the start of her journey, I hope, in Greater Manchester, based on our mantra of prevention, prevention, prevention. Systematic, informed by the best that our technology can provide us with, the best that our integrated health and social care system can provide her with, the best that our hospital sector can provide her with, everywhere, every time she needs hospital care. But hopefully, the best that a new model of primary care-led NHS and health and social care will be able to provide her with, so that her need for hospital care, her need for expensive care is much reduced compared to previous generations. And hopefully she'll live a long and healthy life in direct contrast to, sadly, the problems that we face in Greater Manchester today. Thank you very much.
Thank you so much. It's been fascinating for me to hear about everything that's happening in the Greater Manchester area. We have a little bit of time for questions. So if you could raise your hand if you have a question, and we have a couple of microphones in the room, which we'll get around. I'm going to take them in groups. So if a few of you raise your hands, then we'll get... So could we come to this gentleman first, and then to this lady, and then this gentleman here. So if you go ahead with your question, and then we'll come to you next. Yes.
Hello, thank you very much. Michael
Could
Marsh.
you actually, sorry, I didn't say, could you introduce yourself and say where you work?
Yeah.
Gives us an idea.
Michael Marsh, I'm Medical Director for Specialised Commissioning in London. Absolutely fascinating to hear all the work that's going on, and I just wondered what advice you could give, or how relevant this experiment is to rural parts of the country. So, for example, Devon and Cornwall, or Cumbria.
Thank you very much. Your question?
Hello, Jane Smith. I'm a patient leader for Cheshire West Clinical Commissioning Groups. My question is, as a patient, I live with a lot of long-term health conditions. They're congenital. They're not caused by anything my lifestyle has done. There'll be a number of us who are older people who are living with conditions. Prevention's a bit late for us. How are you going to manage that change from people who are educated in prevention to people who are older, quite a large cohort, who perhaps are unable to do much about their health, or it's basically too late for them, they're frail elderly?
Okay, thank you. And we'll take one more here, and then we'll come back to the panel. Thank you.
Good morning. My name is Darren Feenan, and I work in the private sector. You can guess from my accent, I'm from Northern Ireland, and we have integrated health and social care in Northern Ireland. We have our fair share of problems in Northern Ireland. We have orthopaedic waiting times in excess of 60 weeks. We've got the highest level of mental health problems in Western Europe. And we're trying to sort them out. But I'm just wondering what lessons the panel have taken from parts of the United Kingdom, particularly Northern Ireland, where we continually struggle with things like access to new medicine. Mental health problems are getting worse. smoking prevalence is increasing, and we are struggling to get patients to take hold and work with the medical community to transfer patients' lives.
Thank you. Come back to the panel. Should we start with that point about, particularly challenging parts of the UK and the extent to which you looked at them in putting together your plans in this region?
Go first. Is it working? Good. I think the most important thing about looking at Greater Manchester and very specifically asking what advice we can give to elsewhere, I don't think there's a one-size-fits-all approach to these type of issues. I think there are common features of an approach. I think much of the stuff which we're dealing with has to be looked at neighbourhood and locality level. The other stuff is about what works at scale. And more interestingly, when you start to address health social care, it needs to be addressed in a holistic way with other public services around and become a universal service in the way in which it engages communities. I think we've learnt that. We've done things over the last decade or more and not quite looked at it in the way when we're looking at it now. And I think finally, it's a question of leadership. We've worked very, very hard, particularly over the last 6 months, but as David and others have said, a long time before that, in developing, the trustful, respectful, working relationships involving all the key stakeholders where health and social care and places concerned in Greater Manchester.
Can I just ask, is anyone having trouble hearing that? Yeah, can you just pull your microphone just forward a bit, Howard? Yeah, I think that will hopefully help. Would perhaps then this lady's question about, I wouldn't want to echo what you said about it being too late for prevention, but you made an important point about those who've been living with long-term conditions for a long time. You wouldn't want all the focus, as I understand it, to be on the future. Is that right? Yes.
I'm happy to start to pick that up. If some colleagues are going to answer, they may need a microphone. I guess a key message there, thank you for the question, is that as we know in Greater Manchester, far too many people with long-term conditions are in hospital. And often in hospital, not needing to be in hospital because they're medically fit to be at home. And one of the real challenges we have in the next few months and years is making sure that people with complex long-term conditions, such as you describe, are being cared for appropriately out of a hospital environment. So we have to be much smarter about the pathways of care which enable that to happen. So that's my first comment. The second one, if I may, just in relation to what I think Darren said from Northern Ireland, is as Professor Greer has described, we need to make that journey from research and innovation into practice much shorter and make sure that medicines, for example, which are being developed can get into practice much more quickly and effectively within an environment like Greater Manchester. So I'm not sure that's a lesson for Northern Ireland, but that's certainly one of our high priorities.
All right. David, did you want to say something?
So I've heard people comment that this devolved arrangement is only suitable for urban areas, and I challenge that because I think that many of the concepts that we're talking about know no borders. So when we look at variation in Greater Manchester, you will see variation in rural localities, in rural counties too. So putting our mind to how you determine how to provide reliable care to the evidence of best practice is something that isn't just done in conurbations, it should be done across the whole country. So how practitioners use mechanisms that we will be providing to get them to reach that agreement, how we then support our practitioners, be they operating in the community or in hospitals, to make the right decisions, and how we give them feedback can be done in any locality, urban or rural. And to Jean's point, there are many things that we know we should do differently, and I think that we understand that we can connect people to manage their own health and self-care better if we supported them. We can connect people better to their local communities and to offer better coordination of their care. And so these are things, again, which we are considering. I mentioned the prototyping that we intend to do with the dementia service. And if we can get that right in one locality, then it's easier for us then to spread and replicate that amongst all of the localities of Greater Manchester.
Okay.
And can I just add to all of that, in terms of genetics and genetic conditions, prevention is possible. So we're looking at how we can use the combination of big data and excellent regional genetic service to look at the opportunities around prevention of harm from conditions that you can't completely prevent. So it is possible to take a big data collaborative route to prevention of harm. And in terms of the issues about inequalities, rising smoking prevalence, etc., it's, those are problems that we face in Greater Manchester too, to some extent. And I think the other thing that I didn't say that will be a part of our sustainability plan is going to have to be a new deal with the public. A new form of public sector provision cannot work without an explicit new deal with the public, spelling out the problems we face together and spelling out their role in helping themselves not to come to harm in the first place. Yeah. I think we as a health and social care system so far have failed to do that.
Okay. Anne, did you want to say something briefly before we go to the next question?
Yes, really in answer mainly to Jean's question. And I think that for too long, particularly secondary care, has looked at patients in silos as to whether they're an orthopaedic patient, whether they're a general surgery patient, whether it's cardiology. There is a huge population who have multiple issues and conditions, and we need to be working with those patients around their needs rather than seeing them in those silos. And so, as an organisation, recently we launched a brand new strategy which will be looking at people as the kinds of people we treat rather than those that would be recognised perhaps by the Royal Colleges. And that's where I think we've got to go for the future and where we will go across Greater Manchester.
Thank you. We have a question here, but could you just raise your hand if you have? Can we get a microphone to the lady at the back there? So we'll take your question, and then we'll come to you.
Thank you. I'm Caroline Jessel. I work for NHS England, and I'm the lead for sustainability in the South. So I was really interested to hear Dr. Gill's sustainability strategy and being tough on the causes of demand, which is brilliant. You listed some causes, but the one that you didn't list was more around the stuff that we've done as a medical profession in generating demand, particularly raising anxiety, perhaps over-testing, over-medicalising conditions. And what are we doing about that in Greater Manchester? It's great stuff you're doing, I think.
Thank you. Question at the back.
I'm Valerie Iverson from Salford. I'm a member of the patient panel. No one so far has mentioned carers. The whole system that all these people are talking about will completely collapse within 10 years because of the increasing number of people that Sir David Dalton is to take some progress and look at and plan for, the people with dementia. If the number of people with dementia is increasing, the number of their carers will have to increase. And unless you have lived with someone with dementia, you have no idea of the stress and the strain. And I have said at meetings previously that one day when all the carers jump off a bridge, all you people will then know you have a problem. And there may not be an answer to it today, but I want to make sure that it is raised at the highest level. Thank you.
Thank you very much. Your question.
I'm Alison Page, the Chief Exec of Salford Community and Voluntary Services. I think it's been a really interesting presentation, but I wanted to ask the panel what they thought the role of the voluntary community and social enterprise sector was going to be going forward in Greater Manchester Health and Social Care devolution.
Thank you. Let's start right there then. The role of the voluntary sector in your plans. Who'd like to kick off?
Yeah. Thank you, Alison. We can't do it without you, is probably the key headline. We're still relatively new in our setup, so we haven't got all the answers yet, but there has to be and there will be a key place for the third sector, the community and voluntary sector, within the devolution arrangements. You've got a place on the overall partnership board, which is the overarching governance arrangement for devolution. And we've already had several events, including one big workshop that I attended, where we're trying to think through exactly how we operate with you. Again, not taking away from the great work that is going on at a locality level. How can we add to that at a Greater Manchester level and really make it drive forward? And as ever, I'd say, please give us your ideas as well as us having ours.
Do you feel you haven't been included enough in these plans, although obviously they're in the early stages? Actually, I've just realised you don't have a microphone. Yes or no? Do you feel you haven't been included enough? Okay. Okay. Have been included, and it's happening more now. Anne.
If I can respond to the challenge about carers. Apologies, first of all, for not mentioning carers, because they are fundamental to that. And just to let people know, us up here can also be carers. My husband and I cared for my mother-in-law for a year, brought her to our house. She had dementia and cancer. I know what being a carer is, and if ever I didn't know that we needed to mend what is actually a very fragmented system, it was brought home by that personal way of caring for my mother-in-law. So I saw social care and elements of healthcare completely disjointed. We must have told the story of my mother-in-law 50 times at least over that year. And were we applauded? No. Were we doing the right thing? Absolutely. But we need to do better. So apologies that we haven't mentioned it.
And the point that was made about over-testing and over-medicalisation and the effect on anxiety. Ranjit?
Yes, thank you very much. It's an excellent point. And I'm sorry, my list wasn't exhaustive in terms of the causes of demand. You're absolutely right to talk about provider-led demand, as it's known. A terrible phrase, but and I think what we need to do is work with you, and we're working with Sir Bruce Keogh and his team to try and not reinvent the wheel, but learn lessons from elsewhere in England. But I think part of this actually is to do with that new deal with the public, because part of the drive for testing and absolute certainty instantaneously and, Dr. Google and Daily Mailitis that we in clinical practice experience daily is something we have to address directly with our public. And I think we need to be clear about the capacity and capability of our new system of care, what it can do, what medicine can do, and what it can't do. So I think you make a very valid point. Thank you.
Could we go to the gentleman there, and then could we get a microphone to the gentleman just there? Go ahead.
Hello. I've just expressed a vested interest in this question, that I'm a resident of Greater Manchester. I'd like to ask the panel what plans they have in place to ensure we have a fair share of resources in order to develop this northern powerhouse that really is potentially a political statement rather than a reality. So how are we going to make sure we get our good, effective share of resources for the next 10 to 15 years, please?
Thank you very much. Sir, your question?
Mashood Haq, Bradford Health Watch.
Sorry, hang on. Just say that again. Yeah.
Mashood Haq, Bradford Health Watch. I'm pleased to hear that you're opening your GP services 7 days a week. In my lifetime, can I see that you will be open 24 hours a day?
All right, thank you. And I think someone at the back.
Alyssa Davis from Scope, a national disability charity. It's a question about prevention. We've heard the word prevention a lot today, which is great. I wondered if the devolution deal presents an opportunity to think about prevention in a slightly broader way. So particularly for disabled people, it's not necessarily about improving health outcomes per se. It might be about things like employment or being able to have an active social life or participate in the economy. So I wondered if you had seen a kind of change in the way that you think about prevention as health professionals.
Okay, and I just want to take one more question. Someone here, yes, before we come back to the panel.
Sorry, thank you very much. I'm J.S. Bemra, Medical Director of Manchester Mental Health and Social Care Trust. Fascinating time. Thank you very much, Sir Howard. I just wanted to ask about parity of esteem, because people have mentioned mental health a number of times, dementia particularly, but depression, suicide, stress disorders, Greater Manchester has more than our share of that. And I just wondered whether this would be a fantastic chance for us to, that integration to happen with mental health as well. And Greater Manchester has health inequalities like almost no other city does in England. So how are we going to tackle that? How are we going to get young people who have mental health problems, help them to get back to their job? So mental health, no health without mental health, as they say. So I'd be delighted to hear from the panel.
Okay, thank you. Howard?
First go at the resourcing question,
Yes.
Because that's a question which I'm often asked, particularly by our local authority leaders. The reality is that we have got to bring forward a plan which we're now in the final stages of doing, which justifies a particular bid for resources. Those are resources which would have come our way in any event. The resources which we've actually got to sustain a case for, having regard to the transformation which we're looking to deliver, a transformation process, frankly, which is already starting to change the landscape within which national funding arrangements on health social care are going to be made available. And we're very confident that we've got the essential case to make to justify the resources we're looking for. What is very important, which was one of the more unnoticed aspects of the announcement after the summer budget, was that we have been confirmed to have a carve-out for the National Spending Review for Greater Manchester, where health, social care and public health spend is. So we are effectively negotiating our own spending review allocation over the next 4 years.
Okay. Ian?
Yes, can I pick up the mental health problem?
Yes.
I believe, as I think you do, that mental health is critically important. And it's good, therefore, that mental health figures prominently in Manchester Academic Health Science Centre's work. And I'm sure that will permeate through the whole system. And we've got a fascinating opportunity here, because with the Connected Health Cities project funded by the Chancellor as part of Health North, we can bring together not just health data, but social and civic data. And that's really important for mental health, because some of the signals don't always show up in the traditional medical record system, but rather they can be picked up through social care, where the benefits can also exist. And I can give you a concrete example when it comes to dementia and the earlier question. If we can link up data from the carers and the patients, we can pick up very interesting signals. We know, for example, that when the carer of a patient with dementia receives a prescription for an antidepressant or a tranquilizer, that predicts a deterioration in the patient's problems. That allows you to intervene at an earlier stage, all because we've joined up data from the patient and the carer. We can then take action that can prevent deterioration and support the carer, who's critically important, as well as the patient. So I think there are concrete examples as well as a system that already exists here in Manchester that gives mental health that prominence. And I know that you two feel strongly and that you'll work to continue in that theme within the Academic Health Science Centre.
Okay. Yes, Ian.
Hi. The question about prevention and looking at prevention in a broader and different way, absolutely. What we are aiming to pursue is a social movement for change, which encourages the broadest possible definition of prevention to include people getting involved more in their own communities and being supported by their own communities, for example, because we know that our communities are incredibly strong and incredibly supportive of people, and we need to encourage and support that further. And that links for me to the point that it's very important that we don't paint ourselves, or we're not painted as Greater Manchester working in some splendid isolation from the rest of the country. I think that point's been alluded to. We couldn't be where we are without the support, for example, in this situation, of our colleagues in Public Health England. We've struck an agreement with Public Health England which makes sure that we've got the best possible national and international evidence of what works around prevention so that we can try and put that into place in Greater Manchester. And obviously our work with NHS England is critical to our success.
All right. Ranjit, briefly on the GP opening, and then I'm going to just come to Anne and to David to close.
Thank you. Just on 24-hour general practice, we have the second smallest numbers of doctors per 1,000 population in all of Europe. It takes 10 to 15 years to train doctors. So the short answer is not in the way that perhaps you expect, but we actually already have 24-hour general practice available. It's just not widely understood. And what we're proposing for 7-day general practice in Greater Manchester is not more of the same general practice over wider hours, but a much more focused form of general practice dealing with prevention, health and well-being, and dealing with the missing thousands, treating people more effectively and so on, because that's what works.
We only have 1 minute on the clock, but I just want to come to Anne and David as our two hospital chief executives at the end. You know, everyone here has made very compelling arguments for why this needs to work. But I want to ask you both finally to just be very candid about the biggest barriers. Why, you know, what is it that is going to prevent you? Is it apathy? Is it running out of steam? What is it that is the biggest hurdle you're going to face?
I think the biggest hurdle is going to be changing mindsets. And that is going to be mindsets of people working in health and social care, the leaders in health and social care, and most importantly, the public. We've got a long way to go, but I absolutely believe this is the right time for making this change. We have all the ingredients in place, and together, I think we can actually make that change. This is the only show for Greater Manchester if we want to be that sustainable, healthy, vibrant economy that we believe we should be. So it's mindsets, in my view.
Thank you. David?
It's probably on a similar vein. I think what will get in the way is if our leaders in our healthcare organisations continue to put their organisational interests above the community and the interests of the people that they serve. It's sometimes hard and difficult, and we know not only in this conurbation but across the country, people have an attachment. They define themselves by the place they go to work. I would prefer them to define themselves by the place that they live and the neighbourhoods that they live in and relate to. So subjugating organisational interests to the greater good, I hope, is what we do. And we will find that there is far more that connects us than divides us. And I think that will hopefully make people want to join and be part of, as Ian has said, this movement that's taking place across the conurbation.
Well, as an outsider, I can only say good luck. I wish you well, and I hope that what you achieve then is indeed that beacon for the NHS far beyond Greater Manchester. Thank you very much. Thank you, Sir Howard, and thank you to all the panel.